USMLE, you need to know a lot of things. But for the oncology chapter, you need to only know the chemotherapy stuff. Anything else is not required from you. What I mean by that you should not know every single tumor here. The tumors you will learn in the systems. I mean, when we did, for example, GIT, we learned about hepatocellular carcinoma. You will not learn such a thing here. Yes, we will be speaking about some leukemias and lymphoma, but otherwise the solid organ type of cancers, we will not be speaking about them here. Here, initially, we'll be speaking about hematology. Today, we will be starting about the process where the blood comes from. How is it made? And during embryology, at each month, which organ is producing this blood? After birth, the Abo classification and the RH classification and other minor classification that are important for the USMLE. We'll also be speaking about the erythroblastosis fetalis, which is also known as the Abo incompatibility syndrome and RH incompatibility. And after that, we'll start with general anatomy and histology of different type of RBCs. RBCs, plasma cells, it doesn't matter, all type of blood cells. So let's start with this. Fetal Erythroboisis. Erythro means red, boisis means the process of making something. So fetal erythroboisis occurs in the following. So you can see here we have the yolk sac, liver, spleen, and the bone marrow. So the most initial blood-making organs inside of our body is actually the yolk sac. This is the beginning. This is where it all starts, inside of the yolk sac. So after the yolk sac start making a blood, well, it's not as the same as like our blood as an adults. It's a little bit different actually. But this blood is going to be produced initially from the yolk sac. If you forgot what is yolk sac, remember we had something called amniotic sac and yolk sac. So and between them we had this trilaminar disc, if you remember. So yeah, this is the baby, the embryo, and here we have the amniotic sac, and here we have the yolk sac. And between the two, we had this area. Basically, if I enlarge on this, you can see the amniotic sac and the yolk sac. It's the embryo will be in between. Earlier in life, if we speak about it, they have this basically the developing embryo from this trilaminar disc. Okay, good. So let's start speaking about each portion and each period of time. From 3 to 8 weeks, we have the yolk sac producing mainly we call it the embryogenic globin, which has something called zeta and epsilon. I repeat, this is known as zeta, this sample, zeta. So zeta and epsilon type of globins, and yeah, that's what will be made initially. As you can see, it decreases really quick, and it disappears within the first 8 weeks. After 8 weeks, we don't have this zeta and epsilon type of globin anymore. Then the liver starts kicking in. As you can see, the liver is before the spleen, so the liver starts kicking in, and he started producing from 6th week until birth. And here I want to make you know, guys, and I just want to make sure that you remember that it's true that spleen starts after him at 10 weeks until 28 weeks, but it also stops much before the birth again. So if we're speaking about the spleen stops the process of production much before the birth occurs. Okay, finally the bone marrow, it starts from the 18 weeks until basically like we become adults and we get older in age. It stays with us. So currently as adults right now, the portion that is still working in us, making basically the blood cells, is the bone marrow. Keep in mind that the bone marrow is located within the bone, I mean the tubular bone, the long bone. So that is, for example, the fibula, the humerus, stuff like that. And we have a little bit of it in the sternum. So the hemoglobin development. embryogenic hemoglobin, it has the zeta and the epsilon. And next we have the fetal hemoglobin, which starts to be produced a little bit afterward. So this fetal hemoglobin has an alpha 2 and gamma 2. Before I speak about the alpha and the gamma, I want you to know about our normal hemoglobin as adults. Our normal hemoglobin as adults normally has beta and alpha type of a globin, as you can see here. Okay? So normally as adults, we have alpha and beta, and we call that hemoglobin A1. But for fetal hemoglobin, it's made out of alpha and gamma. Alpha and gamma. Yeah, so it will be alpha and gamma. Fetal hemoglobin has much higher affinity than our hemoglobin. And this is really important actually. Fetal hemoglobin has much higher affinity than our hemoglobin A1. Why? Because if this is for the baby inside of his mother, the fetus inside of his mother, he needs to be able to steal the oxygenated, basically the oxygen from the hemoglobin A1 and transfer it to the fetal hemoglobin. This way, when he does so, the O2 will be transferred from the placenta, from mommy to the baby. So again, I repeat, hemoglobin F has much higher affinity for O2 than hemoglobin A1. And that is due to a less avid binding of something called 2,3-BBG. The lesser binding ability to the 2,3-BBG, the higher the affinity for hemoglobin. This is a concept we are going to learn a little bit later. But for now, what I want you to know, less binding to 2,3-BBG, the higher affinity of hemoglobin to the O2. That allows the hemoglobin F to extract the O2 from maternal hemoglobin. That's what we said, like hemoglobin A1 and A2 across the placenta. So it helps the baby to steal the O2 from his mother. Okay? Good. So, yes. So hemoglobin A2, not A1 now, it's an alpha 2 delta 2, is a form of adult hemoglobin that presents in a small amount. So I repeat, the most common type is this one, A1, which is made out of alpha hemoglobin and beta hemoglobin. Fetal hemoglobin is made out of alpha and gamma. It's much more, has much higher affinity than adult hemoglobin because these patients tend to have much lesser binding to the 2,3-BBG. Okay. Now we go down and you can see here the yolk sac. Initially, it's producing in the first 8 weeks of life. It's producing this epsilon and zeta embryogenic globin that really quick disappears. And after that, we start the fetal period. And this fetal period, during it, we have the liver that starts producing and continue with us until birth. And the spleen that only has from 10 weeks to 28 weeks and then stops working. And after that, we have the bone marrow. You are like, okay, yeah, I see that this is like physiologically and all of this story is kind of interesting. Which organ produces this? Which organ produces that? But what is the clinical significance of this? I will tell you. In case for some reason, let's say leukemia or any other disease, the bone marrow is not working sufficiently. Which organ are going to start to do an extra medullary hematopoiesis? Extramedullary hematopoiesis means blood synthesis outside of the bone marrow. You are absolutely correct. It will be the liver and it will be the spleen. So if the liver and the spleen starts to do extramedullary hematopoiesis, what will happen to their size? Absolutely correct. So this is the exact reason why in case of leukemias we have hepatosplenomegaly. Good. So that's why I wanted you to know about this. Good, good, good. Let's keep going. So now we are going to speak about the blood groups. First of all, the method of transferring blood groups from parents to their sons and daughter, is it autosomal recessive, dominant, or X-linked? What is it exactly? How do we call it? I have to say, this is a tricky question. It's a codominant. We call it codominant. Codominant means that both parents participate in giving the child his basically genotype. Can you tell me any disease that is also transmitted in a codominant fashion? Any disease that is transmitted in a codominant fashion? Absolutely correct. Alpha-1 antitrypsin deficiency. That is correct. So that was Z and W if you remember. But anyway, the important thing I want you to know now that it's a codominant, which means both parents participate in giving the child the disease. So let's take a look at this. So if I say, I need to change the color, just a second. If I say that the parents, well, father has first allele, this is an allele, and he has blood group A, okay? But his blood group A as follows. And the mommy is a blood group B, like this. So in general, I'm going to write them right here. It's unrelated to the example. If I have this, that means my blood group is A. If I have this, that means my blood group is also A. If I have this, that means my blood group is B. Either this or this. But what about this? If I have this, that means what? Anybody has an idea? That means my blood group is O. Absolutely correct. Yep. So this means my blood group is O. So if we take a look at these guys, we need to, well, divide the gametes, we call it. So it happens as follows. You take this and you do like this. Well, what does that mean? Well, you take the first allele, you combine it with this, the second allele. Okay, this is the first child. The next child, again, the first allele, but now you combine it with the second allele. Okay, this is the second child. What about the third child? You do the exact same thing, but in a reverse fashion. So it will be like this. So this is with this, and then with this. So you get yourself, always start with the capital one, like this, and like this. So from two parents having a blood group A and B, you can get one child, which is 25% chance of getting a child with a blood group AB. 25% chance of getting a blood group A, 25% chance of getting a blood group B, 25% chance of getting a blood group O. Okay, so this is important. Why? You will see in a second. If you get a question, yep. So if the parents, if the father is a blood group A, and the mother is a blood group O, can the child be blood group AB? Yes or no? Impossible. That's why high school student discovered that his mother was cheating on his father by him having an AB blood group and his mother being O and his father being A. It was simply impossible. So yeah, he discovered that. Interesting. Okay, so let's keep it going. Good. So we have something called the Abo classification, and we have the RH classification. What is this? What is that? We will learn all about it. So basically, our RBCs, when they are immature, when they are still in the bone marrow, they do have a nucleus. But soon after they are released, they lose their nucleus and all of that. But in the beginning, they do have a nucleus. Inside of the nucleus, you will have the processes of replication, transcription. After that, we have mRNA going out, doing translation, and all of this stuff. what I want you to know that the blood groups are basically kind of this, if you remember when we spoke about presentation of antigen, it's kind of the same thing. So basically what happens that, for example, if we say a patient has a blood group A, what does that mean? It means that on the cell, he's presenting A antigen. Oh, okay, so he has an A antigen on the cell wall. Okay, interesting. Well, why this is where it come from? Basically, and this is important, you need to know that it is hereditary. It is hereditary. Okay, good. So if he has A, he will have anti-what? Anti-A? This is impossible. He cannot have anti-A. If he has an anti-A inside of his serum, the RBCs will get destroyed. So he must have anti-B. Okay? So he will have anti-B, which will not affect this. But if he gets a blood group B in his circulation, it will be destroyed. Okay? So this is just a philosophical question. If you get a question about that, you will never get a question about that. It will be just an annoying patient asking you this. How the hell did you get an anti-B type of antibodies? Well, basically, you will tell him it comes from the food. Some food can have this molecular mimicry and can mimic the type B antigen, which will start making antibody against it. While why we don't make from the food an anti-A? Because you already have it inside of your body. So your body knows that you do have it inside of you. Regardless, in blood group A, we are speaking about the antigen on the RBCs. And this patient will have an anti-B. Keep in mind that this anti-B is an IgM. See, take a look at the size of an IgM. It's pretty big. If it's pretty big, can it go across the placenta? Yes or no? Excellent. It cannot cross the placenta. It's too big. And the clinical relevance, compatible RBC types to receive. Which type of RBC you can take? You can take A or you can take O. Why can I take O? Take a look at O. It does not present any type of antigen. That means I can take it. Well, what about they are saying compatible RBC types to donate to? Who can I donate for him? Blood group A. Well, anybody that does not have an anti-A. Who does not have an anti-A? Somebody with a blood group A. Or somebody with a blood group AB. AB people are really, really selfish. They take it from everybody, but they don't give anybody. Okay? I mean RBCs. They take it from everybody RBCs, but they don't give anybody RBCs. Why? Because the AB blood group has no antibodies in the plasma. So if you give him anything, he will be like, yeah, thank you. It's nice. So blood group B, again, they have the B antigen on the surface of the RBCs. Anti-A, again, IgM, cannot cross the placenta. They are blood group B, so they can donate to somebody who is B, okay? And, sorry, you can give them, I mean the people with the blood group B, you can give them B blood group, also O. O is a universal donor. Remember, if you have no idea which type of blood your patient has and you have to transfer him immediately, you can close your eye, give him an O negative type of blood, and it will always work. Okay, so the next one is an AB. You can see here AB, so it has both the antigen for A and B, and they are located at the surface of the RBCs. They have no antibodies, which is, well, it's good because basically they can take, as you can see, from everybody they can take a blood. Why? Because no antibodies. But the only people they can donate for RBCs is AB. But now I'm going to ask you a super tricky question. Which of the following 4 blood groups can donate plasma only to any type of blood? Plasma only. I did not say RBC, I said the plasma. Who can donate a plasma for everybody? AB, absolutely correct. Why? Because he does not have antibodies, so he can donate the plasma to all of them, but he cannot donate the RBCs. Okay? Who cannot donate the plasma to anybody? Who cannot donate the plasma to anybody? Absolutely correct. Blood group O because he has both anti-A and anti-B. Take a look here. So blood group O has no antigen on the surface. Excellent, no antigens, but he has an anti-A and anti-B. So he has an IgG predominantly and IgM. Oh, well, that sounds suspicious. IgG is much more smaller, so it can or it cannot cross the placenta. It can. So if it can lead to something called Abo Hemolytic Disease of the newborn. Okay? So let's leave it for now, but it can lead to it. People with the blood group O can only take the RBCs from someone like them, but they are generous, which means they can donate the RBCs to everybody. I did not say the plasma. I said backed RBCs. It's different. So, an RH classification. Well, we already spoke about the ABO classification and the different types of antigen presented on the RBCs. Now we are going to speak about another minor type of classification. So we have the RH classification, also known as the rhesus factor classification. So we have RH positive and the RH negative. So the RH positive people do have an antigen on their cell surface called D, okay? D. So this D is existing. If they have the D, logically, they will not have an antibody against it. But if they do not have the D, they will have an antibody against it. So what's up with this? To make it simple for you, if you are a person who forgets quick, remember that O- donates RBCs to everybody. From this, we can learn some stuff. So the RH people, RH positive people, can receive RBCs from both positive and negative, but they can only donate for positive. The O negative, however, can only receive it from negative, but they can donate for everybody. So the worst type of blood to have in a patient, that basically this patient will not donate to anybody. Who is the type of patient who will not donate to anybody? RBCs, I mean. Which patient with which blood group will not be able to donate for anybody? Excellent. It's an AB positive. He cannot donate for anybody. But this patient can donate for everybody. What? He cannot donate RBCs, but what he can donate for everybody? Plasma. Absolutely correct. He can donate the plasma for everybody because his plasma is perfecto. It's nice. Has 0 antibodies in it. Okay, good. So now we speak about hemolytic disease of the fetus and the newborn, and also known as erythroblastosis fetalis. We have an RH hemolytic disease, which is more common, and we have Abo hemolytic disease, which is a little bit less common and less severe as well. So the RH hemolytic disease of the newborn. Well, it happens if mommy is negative. Yep, mommy should not be negative. She should be positive. I'm kidding. If you have a patient, a mommy that is negative, but her son is positive, where the hell did he get the positivity from? Any idea? Where did the fetus get the RH positive from? The father, absolutely. The father gave him the positivity, but regardless, his mother is negative. Well, during first pregnancy, the patient will be exposed to the fetal blood, often during delivery, because, during delivery, we have something called blood mixing. Be careful, it's not only during delivery, I mean not during only like normal delivery, it can be during C-section, vaginal delivery, abortion, molar pregnancy, okay? Anything like this, anything that can lead to mixing of the blood is considered a first pregnancy. So this is the first encounterment between a mother and foreign blood to her. So a patient, which is the mother, is exposed to fetal blood, often during the delivery, and now she starts to make an anti-D IgG. So previously she was negative. Where is she? Here is she. So she is negative. When she is negative, she still don't have this anti-D. Why? Because she never was exposed to it yet. But now after exposure for her, for the basically the RHD from her son, the positive boy, now she's going to make an antibody against him for the future. I mean, this time he passes it through, but the second time, we'll have a problemo. So in subsequent pregnancy, we'll have an anti-D IgG crossing the placenta. So it can cross the placenta. Why? Because it's an IgG. It's much smaller antibody. And it can attack the fetal and the newborn RBC, which lead to hemolysis. We're like, okay, but can it happen in the first pregnancy? The answer is absolutely not. It cannot. Why? Because she does not have the antibody yet. For the sake of getting the antibody, she must have been pregnant before, got an abortion before, molar pregnancy before. But if she did not, she will not have it in a first pregnancy. Subsequent pregnancy, the answer is yes. Okay, we have the antibody killing all of the RBCs in the baby. What will happen? Hydrobus fetalis. Hydrobus fetalis is a condition basically in which the baby is going to have fluid in every single, well, cavity in his body. Ascites, yeah, he will have that. Hydrothorax, why not? He will have it. Well, what about pericardial sac? He will have an effusion of that. What about skin? He will get edema of that. Is it fatal? Absolutely. So the next thing we have here is jaundice shortly after birth and kernicterus. Basically, this baby is having a humongous amount of antibodies against him from his mother. He's a second child. Sadly, nobody liked the second child. So he will get the antibodies and they will destroy all of his RBCs. Now, when you destroy an RBCs, you will get you will get what? What happens after you destroy the RBCs? What you will get out of it? Hemolysis, hemoglobin, heme will be destroyed into iron and protoporphyrin, which is eventually going to make bilirubin. So this bilirubin is going to be unconjugated and it can lead to basically jaundice. And can somebody tell me the unconjugated bilirubin, is it water soluble or fat soluble? Unconjugated bilirubin, exactly, it's a fat soluble that can cross the blood-brain barrier and, well, accumulate inside of the basal ganglia, leading to kernicterus. Okay, what is the treatment and how to prevent it? You prevent it with the administration of the anti-D IgG to an Rh negative mother. So no, we are speaking about the prevention, not the treatment. So you need to prevent it. I mean, like I'm a man, I'm B positive. I know that my wife, for example, is a B negative. She's negative. So I know that, like, she's negative, yeah? So I want to prevent her from making the antibodies, okay? So what I'm going to do is to give her something called the antirogum, okay? So I'm going to give the anti-D IgG to an Rh negative mother during the third trimester, okay? And early postpartum period if the fetus Rh is positive. So if I know that my son is having a high chance of being positive, why? Because I'm positive. So I'm going to give her the antibodies. You're like, wait a second, what? It does not make sense. Why I'm giving her the antibodies? Will not won't that attack the baby's RBCs? Mildly, yes. Mildly, it can cross and attack the RBCs of the baby, but it will prevent the mommy from producing her antibodies. So you will give it during the third trimester to prevent the making of the antibodies during when? When there is a lot of mixing of the blood. When is the most period of time? During delivery, in which we'll have the most humongous amount of mixing of the blood. This period is going to be during delivery. Absolutely correct. So because during delivery we have the most amount of mixing of the blood, we want the titers of the antibodies in mommy to be as least as possible. And to trick the mommy immune system, we do give the antibodies much before the delivery, in the third trimester. So we give her, and then stop. We give her like on 28 weeks, okay? And then just give her a couple of shots and that's it. And next, she delivers at 40 weeks and the titers of antibodies has been down. and she will not have, even if she get exposed, she already had the antibodies, so she will not make new ones. So it prevents the maternal anti-D IgG production. It's a way to trick the mother. Okay, the Abo hemolytic diseases. So it's a, if the mother is a type of blood O and the fetus is type of blood A or B, you're like, wait a second, why this is even a problem? Well, actually the reason is because blood group O has IgGs and IgMs. The IgMs are no problemo, but the IgGs can cross the placenta. So we have a pre-existing pregnant patient with an anti-A or an anti-B IgGs antibody can cross the placenta. If they cross the placenta, they can attack the fetus and the newborn RBCs, leading to hemolysis. So I want you to know one thing. This one is much more lethal than this one, okay? So the presentation will be a mild jaundice because of a indirect hyperbilirubinemia in a neonates within 24 hours of birth. Unlike the Rh hemolytic diseases, which is this one, it can occur in the first babies and usually less severe. Why in the first babies? Because it doesn't really matter. A person who has a blood group O will always have the antibodies. But in case of the Rh negative mother, she needs an initial exposure. Okay, so the treatment is phototherapy. Why phototherapy? Why we do the phototherapy? They can occur together, especially if the mommy was O negative. What the phototherapy is going to make the bilirubin soluble. Do not make the mistake of saying it conjugates it. It does not. It isomerizes it, which means it's going to change its form from one form to another form. It's going to change its form from being fat soluble into becoming water soluble. And if it becomes water soluble, it will be cleared out with the kidneys. Exchange transfusion, absolutely. Well, if you don't have, if your RBCs are getting destroyed, you can give the patient new RBCs. And think about it. If the patient has, which type of RBC we consider it to be a universal donor? Which type of RBCs is a universal donor? O negative, O negative. Remember, O negative gives for everybody. O positive, not for everybody, okay? So O negative for everybody, I mean about RBCs, because why? I did not say plasma. Plasma, no, you are right, but RBCs, you give Rh negative. Why? Because they don't have the antigen. See, no antigen in the Rh negative. So basically, the O does not have antigen, and since it's negative, it does not also have an antigen. So an antigen free. But if you had to, if you wanted a universal plasma donor, which person would you choose? Universal plasma donor will be? Who will be a universal plasma donor? An AB you choose, that's correct. So because he does not have antibodies, and you said plus, which is also correct. Why? Because you needed somebody who has an Rh positive. Why did you choose that? Because he also does not have antibodies because of this. Okay? So, and antibodies are located in the plasma. The antigens are in the RBCs. So if you want to donate the RBCs, you want the RBCs to be antigen-free, which is like the O or the Rh negative. But if you are donating a plasma, you want the plasma to be antibody-free, like the AB or the Rh positive. Okay, good. So let's take a look at the anatomy and the hematopoiesis here. All of our blood cells come from the same cells. It's called the multipotent stem cells, also known as the CD34 positive cell. Okay? So this CD34 positive cells, also known as the multipotent stem cells, we can have two directions coming out of it. A lymphoid stem cells and the myeloid stem cells. I highly advise you to concentrate in these points, because if you understand this, you will save yourself a lot of time trying to study leukemias. So we have a lymphoid stem cells and we have a myeloid stem cells. I'm going to start from the right. If I'm speaking about lymphoboesis, we have lymphoblasts. Can somebody tell me, where is T lymphocyte produced? where is T lymphocyte produced? Absolutely correct. It's the bone marrow. I was trying to trick somebody by saying the thymus, which is wrong. Thymus only maturizes them. It does not make them. So the lymphoblast can make natural killer cells, which are the only innate immune system cells inside of the only lymphocyte that works in the innate immune system. Okay? We also have the T cells and the B cells. For the sake of the B cells to start producing an antibody, it must be converted into plasma cells. Notice, plasma cells have this a little bit of whitish color around it. This is because it's abundant with rough endoplasmatic reticulum. That's why it's whitish around it. So the T cells can have two types, T helper cell and T cytotoxic cells. So the CD4 and the CD8. Okay? So now we speak about the myeloid stem cells. The myeloid stem cells can have many types of cells. So we have erythroboisis, in which we have erythroblast, and then from the erythroblast, which has actually a nucleus, we'll get a reticulocyte. A reticulocyte is the son or the young type of RBCs. And that will be converted into the erythrocyte. In the future, I will be telling you, oh, we have a left shift. Oh, we have a right shift. What does that even mean? Well, basically, the reticulocyte gets converted into an RBC, a mature RBC, right? So if we say somebody has a really, really bad hemolysis, what will happen to his RBC count? Somebody with really bad hemolysis. It will go down, absolutely. So what will happen to his reticulocyte count? His reticulocyte count, obviously, it's going to go up. It needs to make up for the loss, okay? So the reticulocyte count is going to go up because they are the children of the erythrocyte. So thromboboesis. Thromboboesis is making thrombocytes, also known as platelets. It starts from a really, really big cell called megakaryoblast, which gets converted into megakaryocyte. Now this is different. Here we had a cell that is converted into another, different type of cells, like reticulocyte, erythrocyte. But here megakaryocyte, look guys, megakaryocytes make a platelet, but I want you to know how it makes the platelet. It makes the platelet by getting destroyed. It's just the fragments of it, okay? So the just the fragments. Guys, do platelets have a nuclei, yes or no? They do not. They do not have a nuclei. Good. I will tell you later that the megakaryocyte divide to produce the platelet inside of the lung. But for now, this is irrelevant. I will also tell you about the importance of this procedure in which why clubbing happens of our fingers, you know, in case of respiratory diseases. So next thing we have is, let's speak about monocytosis and leave granulobuises to the end. So we have the monoblast, which comes the monocyte. As long as the monocyte is inside of the blood, it's a monocyte. The moment it makes it inside of the tissue, it becomes a macrophage. The last thing is the granulobuises, it's the cells that have many granules inside of them. So they are also known as the Mialoblasts. So we can have eosinophils. Eosino means pinkish. Okay, so you can see the pinkish granular granules. Remember, please, it's interleukin 5 lead to more production of them, and also they are produced to kill the helminth, and also they are increased in case of the allergy. Basophils, you should not see them in the circulation normally. You should not see basophils in the circulation normally. If you do see them, think CML. If you see basophils in the circulation, think CML, which is chronic myelogenous leukemia. Finally, we have the bands becoming the neutrophils, and again we have the concept of shifting to the left and shifting to the right. So if somebody has a B12 deficiency, he will have a hypersegmented neutrophils, which is more mature. So he will have a shift to the right, which is the more mature form. If somebody, however, has a really acute inflammation, he will have a shift to the left, more band, because he needs to encounter the inflammation. Okay, so the next thing is going to be about the neutrophils. The neutrophils is going to be as follows. Acute inflammatory response cells. Remember, neutrophils are acute inflammation. Lymphocytes are chronic inflammation. They have phagocytic function, which means they can eat. Phago means eat the debris, and they have multiple nuclei inside of them, multi-lobes of the nuclei. Specific granules inside of them contains the leukocyte alkaline phosphatase. This will be super important, and it will help us to differentiate if the patient that we have has a leukemoid reaction or leukemias. You're like, wait. I don't know what is leukemia to know what is a leukemoid reaction. Yes, so you are right, but let's explain it. Well, basically, patient can have band, right? And this band can become, I will not go to all of the, there is multiple type of neutrophils, but I'm going to give you like what you need. So the band can be converted into the mature neutrophils, and the neutrophils can be converted to the segmented neutrophils, okay? Multi-segmented neutrophils, sorry. So if we are speaking about somebody alkaline phosphatase, if he has an inflammatory reaction, okay, I'm just going to differentiate between leukemoid, I highly suggest that you write this down. Leukemoid reaction versus leukemia, okay? Leukemoid reaction happens in case of inflammation, an actual inflammatory condition. So if it's an inflammation, the type of neutrophils will be normal, okay? I mean normal neutrophils that produce normal enzyme. So what is going to happen to the level of LAB? What do you think? Leukocyte alkaline phosphatase, in case of inflammation with normal cells, it's going to be up. So the LAB is going to be high. While in case of leukemia, the patient also, like leukemoid reaction, will have a really high amount of neutrophils. Regardless, he will have no inflammation, and the way to check if it's inflammation or leukemia is by checking the LAB. So in this patient with leukemia, if you check the LAB, well, people with leukemia do have a lot of neutrophils, but they are dysfunctional. Because in leukemia, the neutrophils are dysfunctional. What is going to happen to the LAB? It's going down. It's going much more down, okay? So when you see it down, you are like, and somebody said normal. He's thinking, well, yeah, well, it's not working. It should be normal. You are partially correct, but the leukemia cells are kind of assholes. They are like, if I don't work, you cannot work. So they go to the bone marrow and destroy the normal neutrophils, and they take their places, okay? So here we have the specific granules that contains the leukocyte alkaline phosphatase. Also, they have some collagenase, lysozymes, and lactoferrin, which are really important for the sake of destruction of bacteria. And they have something called an azopheric granules, which are the lysozymes. Azopheric means it's not an acid, not a base, that contains, basically it's neutral. Like if you have an acid and at the same time you have a base in the same location, you cannot say it's basic, you cannot say it's an acid. So you just say azerophilic. So an azerophilic granules, lysozymes that contain proteinases, acid phosphatase, mealoperoxidase, and make a note near it, right? It's a green color, okay? So this is why a patient with a pneumonia, when the sputum comes out, the color of the sputum becomes, they say, rusty sputum or a greenish colored sputum. Why it's greenish? Because of the mealoperoxidase. And they also have beta-glucuronidase inside of it. All of these enzymes are really important for the sake of destroying the bacteria. Inflammatory states such as bacterial infection cause neutrophilia, which is an increased amount of neutrophils, and change in the neutrophil morphology, such as left shift. A left shift. Left shift, I will explain in a second, but for what I said about it already, there will be more band than the mature neutrophils. Also, toxic granulation can occur, like a dark blue and coarse granules, which tells you basically that this patient do have an inflammation. And we have something called the Doherty body, in which they are a light blue peripheral inclusions. So when you see something like this, so many granulation inside of the neutrophils start thinking that this patient has an acute inflammation, okay? And cytoplasmatic vacuoles, because they are eating bacteria. So neutrophils' chemotactic agent include the C5a from the complement pathway, interleukin 8, which is from the one of the interleukins, interleukin 8. If you remember, I told you that it can keep even the inflammation going because it looks like infinity. Leukotriene B4, only the leukotriene B4. And to make leukotriene B4, we had to convert the arachidonic acid into leukotrienes utilizing the 5-lipoxygenase pathway. And the 5-HETE, which is a leukotriene precursor. Also, kallikrein and the platelet activating factor. And the most important thing for me personally is the bacterial protein known as the N-formyl methionine. This will be tricky. I don't expect anybody to know what that is. But do you remember where did we see N-formyl methionine? Any idea? We saw it somewhere. N-formyl methionine. I told you, yeah, it's a chemotactic agent and all of that. But it had one importance, if you remember. Any idea? Well, I did not expect you to remember it. Actually, it's kind of tricky. Remember, in our cells, human cells, if you want to start and initiate the process of replication or transcription, the first amino acid to be translated was methionine. But for the sake of bacteria, the first amino acid to be dealt with is N-formyl methionine, which is highly specific for the bacterial cells. Okay, hypersegmented neutrophils, which have more than 6 lobes, can be seen in B12 deficiency and folate deficiency. Between these two vitamins deficiency, which one between them will have neurological symptoms? Well, actually, it's going to be B12 deficiency. B12 deficiency will have neurological symptoms, while folate will not have neurological symptoms. Do not confuse this with a neural tube defect in the babies. That's totally different. So the left shift, we have a neutrophil precursor, such as the band and the metamyelocytes, will be increased in the peripheral blood much more than the mature type of the neutrophils. They reflect an increased myeloid proliferation, which can be either inflammation or CML. Damn it, how can I differentiate between this CML and inflammation? It can be leukemia, it can be inflammation. Which test you should do if you are not sure if this is increased? Well, basophil is correct, you will see it in CML. But there is a test, a biochemical test that you can do, and you can know if it's leukemia or leukemoid reaction, basically inflammation. Excellent, it's the LAB. And if the LAB it is high, it's inflammation. If the LAB is low, it's going to be leukemia. Leukoerythroblastic reaction, it's a left shift combined by immature RBCs. It happens when we have infiltration of the bone marrow, and I will explain why it happens. Just a second. Okay, I'm a really bad drawer, so just don't be harsh on me. So this is a bone, okay? Inside of the bone, we have a bone marrow, right? If somebody has a leukemia, let's say, or myelofibrosis, and all of this leukemia or myelofibrosis is infiltrating the bone, it's going to squeeze the immature cells out, right? So that is going to lead to so many immature RBCs and leukocyte inside of the circulation. And we call that a leukoerythroblastic reaction. Again, it's due to myelofibrosis or a leukemia or any type of cancer infiltrating the bone marrow, kicking out the immature RBCs and the leukocyte, leading to a left shift in both the RBCs and the neutrophils, and we call that leukoerythroblastic reaction. Okay, guys, so we'll take a 10 minutes break for now. We'll come back and we will keep pushing. See you guys in 10 minutes. Hello everyone, welcome back. Let me just share my screen 1 second. Can you see my screen, please? Can you see my screen? Okay, perfecto. Let's start this. So now I'm going to start speaking about RBCs. How long does RBCs live inside of our body? 120 days. Okay, plus or minus. So let's take a look. RBCs, also known as erythrocytes, their main function is to carry the oxygen to the tissues and the CO2 back to the lung. Keep in mind that the CO2 is not only transported by the erythrocyte, but it can be transported by the plasma as well. They are enucleated, which means they do not have a nucleus and they do not have organelles. So do they do electron transport chain and oxidative phosphorylation, or, well, how can they consume the glucose if not that? I mean, how can they make the ATP? The answer is anaerobic glycolysis and HMB shunt. So they write, with a large surface area to volume ratio for a rapid gas exchange. If you take a look at an RBCs, it looks like this. I mean, if I take a cross section of an RBC, it looks like this. Oh yeah, I really suck at drawing. Yep, it looks like this. So the reason that it's biconcave like this is to increase the surface area, okay? And to make it be able to bend around. If we speak about an RBC, guys, it's flexible. It can be flexed up, down, right, left. You can squeeze it. I mean, it's in diameter from here to here. It's, yes, when it's young, it's 8 micrometers. But when it gets older, it becomes much more stiff. So this 8 micrometers, it can go through a 3 millimeters vessel. So it can go through a 3 millimeters vessel. But when it gets older, it cannot do this anymore. So that basically means that if it goes through this at like when the RBC is a little bit older, it will be stiff, and it tries to go through this 3 millimeters vessel, it will just simply burst. It just will get destroyed, basically. So what they write here, the lifespan of an RBC is 120 days in healthy adults and 60 to 90 days in neonates. The source energy of them is anaerobic glycolysis. So glucose is the main thing. Remember, brain and RBCs mainly use glucose. So 90% is used by glycolysis, and the last 10% by the hexone monophosphate shunt. These two processes we'll speak about when we discuss the metabolism chapter in the biochemistry. 90%, membranes contain a chloride bicarb antiporter, and this antiporter will speak about the clinical significance of it and transporting the CO2 and other BH related stuff a little bit later when we discuss the pathologies. So yeah, and transport the CO2 from the periphery to the lung for elimination. So basically what they write here, different words, and what do they mean? Erythrocytosis is the same as saying polycythemia, which increases which means increase in the hematocrit. Anisocytosis, aniso, it has an S, so it's the size stuff. So it's the anisocytosis is the size problem, while bucilo, it's the shape stuff. So when they say anisobuchylocytosis, it means that they have disturbances in the size and shape, and you need to think about some type of a deficiency. Reticulocyte and immature RBCs reflect erythroid proliferation. The bluish color polychromasia on a right GM stain of the reticulocytes represent residual ribosomal RNA. So sometimes these reticulocytes, which are immature RBCs, can have what? Can have a little bit of a stain inside of them, a bluish stain, which is basically known as like polychromasia, and that is basically residual ribosomal RNA, rRNA, which is the thing that normally makes the proteins and make the ribosome structure. It used to make the ribosomal structure. So the next thing we are speaking about here, let me just make sure I'm recording. Okay, that's good. The next thing we are going to speak about right here is going to be the thrombocytes, also known as platelets. So it involved in a primary hemostasis, which is basically like the blood, like the stoppage of the bleeding. Also, it does not have a nucleus, and basically it's a small cytoplasmatic fragments which comes from the megakaryocyte. Remember what I told you. A megakaryocyte is the precursor, is a big cell, and the fragments of it are known as platelets, right? So that's what is written here. So the lifespan is only 8 to 10 days, and when activated, what gets them activated? Well, they can be activated by endothelial injury. I will be explaining exactly how this happened, but just a quickie. This is endothelial cells. Under it, there is collagen. When the endothelial cells will be destroyed, they will expose the subendothelial collagen. The subendothelial collagen will be binding to something called the von Willebrand factor. The von Willebrand factor actually does come from the platelet and the endothelial cells themselves, but mainly from the platelets. After that, the von Willebrand factor is going to bind the platelet together. And when the platelet bind together, we call this process aggregation. After this aggregation happens, more aggregation will occur, which basically help in the creation of a thrombus or a platelet block. So here they write, when activated by endothelial injury, aggregates with other platelets and interacts with fibrinogen to form a platelet block. It contains, the platelet, it contains inside of it two types of granules. One is called the dense granules and the other one is called the alpha granules. So the dense granules, he's dense, he's full with cash. So cash, that will be the calcium, which is also known as factor 4 for the clotting cascade. So it's important in the coagulation. ADP as well, serotonin and histamine. While the alpha granules, on the other hand, contains the Fs, a lot of Fs, guys. So that will be von Willebrand factor, fibrinogen, fibrinonectin, platelet factor 4. Approximately 1/3 of the platelet pool is stored in the spleen. So we have a plenty of platelet in the spleen, and we only use them in cases of emergency. So thrombocytopenia, or a decrease in the platelet function, results in petechia. I want you to make a note. The normal amount of platelet in our body is between 150,000 until 400,000. We start developing symptoms only when the platelet count go under 30,000. So you can see there is a huge gap between the thrombocytopenia and the actual symptoms development. Okay, so how can I differentiate between petechia and, let's say, vasculitis? The answer is simple, with your finger. You will put your finger on the petechia. Exactly. You will put your finger on the petechia. If it's blanching, which means it disappears, this is a petechia. If it does not disappear, this is vasculitis. Von Willebrand factor receptor, also known as the GB1B, it's located on the platelet itself. And fibrinogen receptor is known as the GB2B3A. It's located also on the platelet, but these are different as follows. So the difference between these two goes something like this. As you can see here, the von Willebrand factor binds to the GB1B, which is coming from here. It helps binding to the subendothelial collagen. While the GB2B3A, it's basically binding two platelets together, which help in the process of aggregation. And notice, for the sake of them binding together, it needs a particle in the middle known as fibrinogen. Fibrinogen was one of the last part of the clotting pathway. Okay, so let me go up here for a second and continue. So they write also that the thromboboetin stimulates megakaryocyte proliferation. Remember, thromboboetin is produced by two organs. The first organ is the liver and the second organ is the kidney. So people who have who have cirrhosis, for example, tend to have less thromboboetin. In the same time, they are sequestering the platelets inside of their liver and inside of their spleen, which lead to thrombocytopenia. Okay, alpha granules contains the Fs, von Willebrand factor, fibrinogen, fibrinonectin, platelet factor 4. alpha. It has an F, so a lot of Fs. Don't forget about the catch, especially the calcium. It's factor 4. Monocyte, as long as it's in the circulation, it's monocyte. The moment it goes to the tissue, it becomes a macrophage. So it's found in the blood, and it can differentiate into macrophage in the tissues. So it's a large large, and it has a kidney-shaped nucleus. Notice, the size of it is like 3 RBCs combined. And if you take a look at the lobes, it has this kidney shape. I mean the nucleus, right? So you can see it's like kidney-shaped nucleus. And it has this frosted glass cytoplasm in it. Okay, so mono means one in nucleus and cell. So just remember, the monocyte becomes a macrophage when it enters the circulation, when it enters the tissue. And this is super important because it helps in the creation of giant cells in case of tuberculosis. Okay, so macrophages. Well, here comes the guy. Remember, monocytes become macrophage if it enters the tissue. Its main function is to phagocytose the bacteria and also the cellular debris. What is cellular debris? Well, let's say you did apoptosis. You made a lot of apoptotic body and you want to get rid of them. So the way to do that is with macrophages by phagocytosis. Also, if you have an old RBCs that they are old and getting destroyed. So let me tell you exactly how this process happens. So let's say that this is a sinusoid inside of the spleen. It's a 3 to 5 micrometers in length. Can someone tell me what is the diameter of the RBC, normal RBC diameter? It's 8. So it will be like this. So how the hell this thing can fit in this? How can it fit? Yeah, it's flexible. It's flexible. It just can flex and go, and it just does not really care. It will be like, like this. Okay, so it will pass. But when it gets older, it will become really, really stiff, right? So now it's like this. It's like an old grandfather. So if it tries to go in, what will happen? The answer is going to break, absolutely. So it's like, and it gets destroyed to many pieces. And who's sitting here waiting for that to happen? Macrophage, they will be like, finally, some food, let me eat. So they will consume it, okay? This process is happening inside of the spleen. So they write, differentiated from circulating blood monocyte, I mean the macrophages, and they can be activated by alpha interferons. Remember the gamma interferons, and remember this was really important for the sake of creating granulomas. It can function as an antigen-presenting cells via MHC class II, and we know that only few cells do have the MHC class II, only the antigen-presenting cells, which include B cells, dendritic cells, and macrophages. So they can also important cellular component of the granuloma formation, like TB or sarcoidosis, where they may fuse together to create a giant cells. So if you get a question on the USMLE showing you a granuloma in case of sarcoidosis or TB, remember TB has a caseating, sarcoidosis non-caseating. So why TB is caseating? Because it's infectious. Sarcoidosis non-caseating because it's non-infectious. So if they show you a giant cell and they are like, which type of cell is that? Be like, well, it's a macrophage. So macro means big, phage means an eater. Macrophage naming varies by a specific tissue. For example, they are called Kupffer cells if it's in the liver. Histiocyte in the connective tissue, Langerhans cells in the skin. Do not make a mistake of thinking it's Langerhans cells. Langerhans cells, it's in case of tuberculosis. Langerhans cells, it's the macrophage of the skin. They are called osteoclast in the bone and microglial cells in the brain. In the lung, we call them dust cells in the lung, okay? Okay, so if you get a question about which of the following cells can be, by the way, guys, can somebody get HIV in the macrophage? Can someone get, he can. Remember that when we spoke about 2 receptors of HIV, we said like one of them was like the 4-1. It was on the CD4 cells. And we also spoke about, I think its name was the CCR5, and that one was also in the macrophages. Okay, so HIV can also infect the macrophages. That's what I want you to know. So if they are telling you about brain tissue and the patient with HIV, and they ask you which of the following cells do you think it has the HIV in it, you have to say, well, it's the microglial cells because it's a macrophage of the brain. Lipid A from bacterial lipopolysaccharide, remember it is only in the gram-negative bacteria, can bind to the CD14, and after it binds to the CD14, it can release a lot of cytokines which can promote to septic shock. So it can promote to septic shock by doing that. So eosinophils, on the other hand, they help to defend the helminth infection by releasing a major basic protein. So they help to destroy the helminth by making let's say that this is a helminth, this is eosinophils. He comes, he releases basic major protein, and it makes plenty of holes inside of it, and a lot of histamine is going to attack, which lead to the helminth to just simply burst. Okay? It has 2 lobules of the nucleus inside of it, not the 3. If it's a 3, starts thinking neutrophil, and it's pink. So it's backed with a large eosinophilic granules, which means pinkish granules, of a uniform size. Highly phagocytic for an antigen-antibody complexes. So there's a few things that you must master in the sake of eosinophils. There is a few diseases that there is high association with eosinophil with. I like the fact that they put them all in Buckman here. So we'll speak about all of these in a second. But for eosinophils, they can produce histaminase and major basic protein, which help to kill the what? It helps to kill the helminth, okay? Not for the allergy. So major basic protein and helminthotoxin, which kills the helminth. Eosinophil peroxidase, and we have the eosinophil cationic protein and an eosinophil-derived neurotoxin. All of these stuff are super important for killing the parasites. But what is interesting that in the developed world, there is not a lot of parasites. So because of that, we have, well, this is a theory, of course, I'm saying. I'm not saying that this is totally true. I'm just telling you the theory in medicine right now. So they said because in the developed world, there is not a lot of helminths, people started getting which other type of infection? Not infection, sorry. Which other type of disorder? Allergies and asthma. Absolutely, allergies and asthma. So we truly don't know the exact cause of asthma. We know the pathogenesis, but we don't know the exact thing that is leading to it. So yeah, that's interesting. If you can find something, you will get a Nobel Prize. So an eosin means a pink dye, philic means loving. So we have the parasite, asthma, chronic adrenal insufficiency. Also, this patient will have it. You are like, what the hell? How come? It's not related even to it. Well, adrenal gland do produce glycocorticosteroids. When the glycocorticosteroids are absent, eosinophils are going to be higher. Also, in case of myeloproliferative disorders, especially in the myelogenous one, allergic processes will increase it. Hodgkin's lymphoma, especially with the eosinophilic rich type. And eosinophilic granulomatose with polyangiitis, also known as Church-Strauss disease. Remember, in Church-Strauss disease, this patient did also have asthma. They had also what? They had neuropathy, asthma, and they had kidney disorder, and one more thing, which was upper respiratory tract problem. Okay, so let's speak about one more thing about eosinophils I forgot to mention regarding the kidney. Which disease of the kidney can have high amount of eosinophils? Which disease of the kidney can have high amount of eosinophils in the urine and in the blood? It can be after somebody used, like, for example, allopurinol, indomethacin, NSAIDs. Well, what is it? Exactly, that's a story with a girl. I totally agree. It is the same disease. That girl, what disease did she have? The answer is interstitial nephritis. Interstitial nephritis, guys. So interstitial nephritis. It's interstitial nephritis. Really common nowadays, especially with a lot of people taking the drug. Okay? So the basophils. It mediates allergic reaction as well. And basically, they are densely basophilic granules inside of it. Basophilic means blue. Basophilic means blue. Eosinophilic means pink. Okay? So basophils, they will have plenty of densely basophilic granules inside of them, and these basophils are going to contain heparin. Okay? So they contain heparin, which is an anticoagulant. And this anticoagulant, well, it will have a function because it also can help in destroying the helminths. Also, it has a histamine which can work as a vasodilator. So leukotrienes can be synthesized and released on demand. Guys, to be totally fair with you, they don't give a shit about what it has or it has not. They only care about one thing. If you see it on the blood smear, think what? If you see a basophil on the blood smear, you should not think about, there is not a lot of things to think about. Think CML. Think CML. So basophilic stain readily with basic stain, which is bluish stain. Basophilia is uncommon, but can be a sign of myeloproliferative disorder, particularly CML. If you see basophils, CML. Okay, the mast cells. Mast cells are also for allergic reactions. So many things for the allergy. They contain also a basophilic granules. They originated from the same precursor as the basophils. Okay, so they are kind of the same thing, but you will see now what is different. Basically, what I want you to know, basophil is not the same story as monocyte and macrophage. They are not the same cell, okay? But they have the same father, basically. So they originated from the same precursor as the basophil, but they are not the same cell. Monocyte became macrophage, but basophils did not become mast cells. They are totally different cells. They can bind to the Fc portion of the IgE to membrane. Well, what does that even mean? Well, this is a mast cell, and this is the Fc portion of an antibody. And if we are speaking about an Fc portion of an antibody, this antibody, of course, in its epitope, it's going to have something. What is going to have? Something that is presenting on it. An allergen. And, well, basically, let's make one more antibody. Let me just tell you what happens exactly. This is a mast cells, and this is an IgE, okay? So you will have two IgEs on the same location. Let's say that I'm allergic to, I don't know, nuts, okay? Nuts. I'm allergic to nuts. I consume nuts, and nuts is going to lead to cross-linking of these two IgEs. When this cross-linking will occur, the mast cells is going to degranulate and release plenty of histamine and serotonin, which is going to lead to a massive allergic reaction inside of me. But for the sake of getting that, the first thing that I needed to have is the IgE to be primed against the nuts. So I should have been exposed to the nuts before, okay? So, okay, this is an IgE-mediated mast cells degranulation. There is something called an IgE-independent mast cell mediated, an IgE-independent, that means it does not require an IgE, mast cell degranulation. This is totally different. So the mast cells, they write, it can bind to the Fc portion of the IgE to the membrane. It's activated by tissue trauma, C3a, C5a, and also surface IgE cross-linking by an antigen. An IgE receptor aggregation is what I just drawn for you. It can lead to degranulation, which releases histamine, heparin, Oh, I remember they used to ask about this one a lot, tryptase. And an eosinophil chemotactic factors. So the mast cells can call for their friends, eosinophils, to come and give more histamines and more basically allergic particles. The mast cells, guys, the mast cells also do one more thing. So here they write tissue trauma. Yeah, true. When you get a hit, the mast cells can degranulate. But now I'm going to tell you something you will never forget about. If you are doing cardio, you are running on the treadmill for, let's say, half an hour straight at a really high speed, and you suddenly stop, you are going to feel a little bit of burn in your body, I mean on your skin, okay? This burn or burn/slash itchiness that occurs, it's a histamine mediated, and it's happening because of the mast cell release. It only occurs the moment you stop. As long as you are going, you will not feel it, but the moment you stop, you will get it. Okay, so it's a burning-like sensation that occurs on the skin after a long run, especially marathons. So involved in type 1 hypersensitivity reaction, which is an IgE mediated, obviously. And we have something called the cromolyn sodium, which is an anti-asthma drug. It prevents mast cell degranulation. It becomes as a inhaler type of thing. It has like a capsule. I will just show you the device because it's not used as much these days because we have much better medication. But you need to know it. You need to know it. So if somebody says about it in front of you. So, okay, you are like, well, some medication, it spells? Yes and no. You will understand what I mean in a second. Yes and no. So, it has an inhaler type of thing. But, oh yeah, good. You can see it here. Okay, so it comes in an inhaler, and that will lead to stabilization of the mast cells, which prevent them from degranulating. Okay, so the next thing we have here is something called an IgE independent mast cell degranulation. If it's IgE independent, is it a true type 1 hypersensitivity reaction? Yes or no? If they write it's an IgE independent mast cell degranulation, it is not. Excellent. It's not a type 1 hypersensitivity reaction, which means, well, this guy is getting like the degranulation happening after consumption of vancomycin, opioid, or radiocontrast dye. Well, what does that mean? I mean that mean if somebody gets mast cell degranulation because of taking of one of these drugs once, if he takes them again, will he get it again? If he consumes this medication again, will he get this reaction again? The answer is not. You just need to administer them at a slower fashion. The vancomycin, opioid, and the contrast can directly bind to the mast cells and lead to the degranulation. Yes, you are right. So, because of that, you can just increase the hydration of the patient and administer the drug for a longer period of time in a slower fashion. Okay? That's it. He will not have the reaction. And if you really like your patient, give him diphenhydramine with it, which is an H1 antagonist that is going to reduce the allergic response. So mastocytosis is quite rare. It's a proliferation of the mast cells in the skin and outside of the skin. Its association with a c-KIT a mutation and increase in the serum tryptase. Why serum tryptase? Yep, you guessed it, because the tryptase is existing inside of the mast cells. And he's kind of specific, guys, because no other one has a tryptase in it. Obviously, they will have more histamines, which will lead to flushing, pruritus, hypotension, and it's going to lead to abdominal pain, diarrhea, and peptic ulcer disease. People tend to get surprised when I tell them peptic ulcer disease. They're like, how come? How come histamine can lead to peptic ulcer disease? Well, if you remember, guys, we spoke about this already. If you remember, I told you that histamine can bind to the H2 receptor. Yeah, gastrin used to induce histamine as well. Yeah, H2 receptor, which increases the cytokine B, which means the hydrogen potassium bond is going to work overtime. The overtime work for the hydrogen potassium bond means basically you are getting yourself much more HCl, which is going to increase the chance of you getting an ulcer. Okay, good. So let's keep going. Dendritic cells, a highly phagocytic. First of all, it's an antigen-presenting cells. Remember, B cells, dendritic cells, macrophages. I'm not sure what do you mean by is so the body is synthesized. For what exactly? If you are asking about the vancomycin, right? Here is the thing about the vancomycin opioid and the radio contrast. This is the thing. There is no actual synthesization process. Why? Because I told you, it just directly, the drug will directly bind to the mast cells and lead to the degranulation. We say the drug is synthesized when it is IgE dependent, but in this case they write it's independent, which means there is no synthesization. The vancomycin opioid and radiocontrast type of mast cell degranulation can happen in any patient. It means if you give me this medication really fast with a huge amount IV, I will also develop it, regardless of the fact that I have zero allergy to it. It's just like a side effect, you can think about it. So dendritic cells, a highly phagocytic antigen-presenting cells, function as linkage between an innate and the adaptive immune system. Remember that is mostly like under the skin. It can bring an antigen from under the skin and take it to the lymph node. I will give you an example with leishmaniasis, which they love to ask about. A patient gets bitten by a mosquito known as the sandfly. This sandfly, after biting him, is going to defecate and release a lot of leishmania inside of his skin. The dendritic cells is going to consume the leishmania and take it back to the lymph node where it's going to be processed. The dendritic cells is an antigen-presenting cells, and it's going to present the leishmania antigen to the cells inside of you, to your B cells and memory cells, which are going to create a memory cells against it, and also they're going to make antibody against it. Express MHC class 2 and FC receptor on the surface. Yeah, why MHC class 2? Because it is a antigen presenting cells. It can present exogenous antigen on the MHC class 1, basically cross representation. It can express on it both endogenous and exogenous. Okay, dendritic cells are cool. They are mostly on the skin, and if you look at them, they do have this dendrites on them. That's why we call them dendritic cells. Lymphocytes, we spoke about them already, but let's do it again. So we have lymphocytes. They are referring to the B cell, T cell, and natural killer cells. The only one here that is an innate immune system is natural killer cells. Absolutely correct. B cells and T cells mediate the adaptive immunity, while the natural killer cells is a portion of the innate immunity. Rough, densely staining nucleus with a small amount of pale cytoplasm. As you can see, the whole thing is like a nucleus with a little bit of cytoplasm. Okay? So, the natural killer cells, these guys, I told you, they are stupido. Important in the innate immune system, especially against intracellular pathogens. I will explain what's up. Well, basically, this is a cell. Okay? Let's say that we have a virus. This is our normal cell. She's happily ever after. Okay? So she's happy, and now a virus comes inside of it. She's like, help. So when she asks for help, she's presenting the virus on its MHC, correct? MHC class 1, of course. So it's presenting the virus on the MHC class 1. Who see it? The natural killer cells. When the natural killer cells see the cell that is virally infected asking for help, what does he do? He kills it. Okay? So he kills it using gran enzyme and peripherins. So again, the virally infected cells is going to present the virus on its cell wall utilizing the MHC class 1, and when the natural killer cell sees that, it kills it. So it's a larger than B and T cells with distinctive cytoplasmic lytic granules containing peripherins and the gran enzyme that, when released, acts on a target cells to induce the apoptosis. Distinguish between healthy and infected cells by identifying the surface protein which are present on the MHC class 1. It can be induced by stress, malignant transformation, or microbial infection. Again, anytime the MHC class 1 is going to be altered on the cell, the natural killer cells don't think a lot. You see altered MHC, which can be because of cancer of the cell, which can be because of infection of the cell, or it can be because the cell is tired. He simply just kill it. Remember that it does have on it a CD16 and the CD56 on it. This CD16 can bind to the Fc portion of the antibodies. So let's say we have a bacteria, and the bacteria have a binding to the Fab portion with the antibodies. The natural killer cells is going to bind to the Fc portion of the antibody and can release the peripherin and the Gran enzyme to kill the bacteria as well. So he can help in killing the bacteria itself and also in the virally infected cells. Keep in mind that both of these actions are innate immune system and not an acquired immune system. The B cells mediates humoral, not cellular, humoral. So the B cells is humoral, the T cells is cellular. So the B cells mediate the humoral immune response, originate from the stem cells in the bone marrow and mature in the marrow. So B for bone. Migrate to the peripheral lymph node, the follicles of the lymph node, the white bulb in the spleen, and an encapsulated lymphoid tissue, like, for example, the Bayer's patches. When the antigen is encountered, B cells is going to be differentiated into plasma cells, which makes the antibody, and also it can become a memory cell. If you get a question, which of the following is can be a memory cell? Answers are B cell, T cell, B cell, and T cells. The answer is B cell and T cells. Both of them can become memory cells. They can function as an antigen-presenting cells. So for the T cells, they mediate cellular immune response and originate from stem cell in the bone marrow, but mature in the thymus. Yes, the T cell. Oh, before I forget, take a look at the CDs on the B cell. So they can be CD19, 20, CD21, and CD10. Okay. So now the T cells. The T cells can be either CD4 or CD8. Both of them has the CD3. They mediate cellular immune response, originated from the stem cells in the bone marrow but mature in the thymus. They differentiate in the cytotoxic T cells and express the CD8, which recognizes the MHC1. Remember the rule of 8. Or they can basically have they write here, can express the CD4, which recognizes the MHC class 2. So 2 multiplied by 4 is also 8. And regulatory T cells as well. The CD28 is a co-stimulatory signals, which is important for the T cell activation. And most circulating lymphocytes are T cells. This is actually important. So if you see a lymphocyte and they are asking you, most likely this cell is what? Be like, well, most likely it's a T cell. Do not make a mistake of when they ask you about atypical reactive lymphocyte in case of EBV. They ask you, is it a B cell or a T cell? You must choose T cell in case of EBV. The last thing is plasma cells. It produces large amount of antibody specific to a particular antigen. They have this clock phase chromatin distribution and an eccentric nucleus. What does that even mean? Well, let's take a look at a plasma cell and let me try to help you to understand what does that mean. So a plasma cell produces plenty of antibodies. Because it does produce plenty of antibody, its rough endoplasmatic reticulum must be overdeveloped. Okay? So as you can see, this is a nucleus. This pale area around the nucleus, this is rough endoplasmatic reticulum. Okay? So let me do this. So you can see this area. This is rough endoplasmatic reticulum. This is the nucleus. This is the cytoplasm. Okay. Good. So they have an abundant rough endoplasmatic reticulum as well as a well-developed Golgi apparatus. They found in the bone marrow and normally do not circulate in the peripheral blood. Okay, multiple myeloma is the plasma cell dyscrasia in which we'll have a hyper proliferation of the plasma cells inside of the body. What about this clock phase chromatin thing? Well, if you take a look inside of the nucleus, you can see whitish dot. See, 1, 2, 3, 4, 5, 6. They say that it looks like a clock. It takes a little bit of time for you to be able to become for you a second nature in which you can recognize it easy. But yeah, it does exist. So just a second. Yep, so you can see here the chromatin is clumping. Can you see the clumping of the chromatin? They consider it to be looking like a clock. Okay, so let me send you this. Okay, so let me just take a look what he have finished so far. 1, 2, 3, 1, 2, 3. Okay, guys, so let's take 10 minutes break, and I will see you guys after the break. Hello everyone, welcome back. Can you see my screen, please? Excellent. Okay, so let's continue. Now I'm going to speak a little bit more about the hematology. I'm going to, well, you decide, guys, genetics or hematology. Just right, I will take as the first two comment, genetics versus hematology. Okay, hematology 1, hematology 2, and that's it. Okay, hematology. I see you are liking hematology. It's a really interesting subject. There is a lot to learn here. So the next thing we are going to speak about is the physiology. It's a little bit more difficult than the previous topic. We are going to speak about the electrophoresis process. So here we are going to basically bring media, fill it with jelly, okay, and then put an electrical wire on it. The negative end is here, the positive end is here. The negative, we call it a cathode, the positive, we call it an anode. And the electricity is going to pass from negative to positive. According to the weight of according to the charge and the weight of the particle, it's going to be distributed. So let's see what I mean by that. Of course, now we are dealing with what? With RBCs. So they write, on the gel, hemoglobin migrates from negatively charged cathode to the positively charged anode. Hemoglobin A migrate the farthest, followed by hemoglobin F. So let's take a look. See, hemoglobin A is here. So all of these are hemoglobin A, and A. While hemoglobin F is going to follow him shortly. And after that, we have the hemoglobin S, and the least will be hemoglobin C. So this is because the missense mutation of the hemoglobin S and C replaces glutamic acid, which is negatively charged, with valine and leucine, which are positively charged. So because positively charged particle like the negative. Remember, positive and positive, they repel away from each other. So because leucine and valine are positive, they will run away from the anode. So they will be near the cathode. Okay, so making the hemoglobin C and the hemoglobin S more positively charged than the hemoglobin A. Okay, because hemoglobin S and A are more positively charged, they are going to run away from the anode and go towards the cathode. So you can see here, if the patient has 2 alleles of hemoglobin A, all of it will be near the hemoglobin A stuff. Hemoglobin A and F, so the A will be here, the F will be here. The sickle cell triad, one of them will be A, one of them will be S. Sickle cell disease, both of them will be SS. Hemoglobin C triad, which is, as we said, it's like when you change, it's a missense mutation in which you are changing the glutamic acid with lysine, okay? And the hemoglobin C disease, in which you have 2 alleles of hemoglobin C, and SC, which we have 1 allele of hemoglobin S and 1 hemoglobin of hemoglobin C. So they write here the Coombs test. So the Coombs test is something like this. It helps you to detect the antibodies either on the RBC or in the serum, also called the antiglobulin test. Detects the presence of antibody against circulating RBC. We have direct and indirect. The direct one is an anti-immunoglobulin antibody, Combs reagent, added to the patient RBCs, and the RBCs agglutinate if the RBCs are coated with IG, used for autoimmune hemolytic anemia. Basically, what we are doing, we are checking if the patient RBCs have antibodies on them. So if you are checking the antibodies on the RBC, we call it direct Combs test. If you are checking the antibodies in the serum, we call it indirect Combs test. So in the direct Combs test, what do? We add anti-human globulins, which is the Combs reagent, which are going to only bind to the what? To the antibodies. Okay? So if there is no antibodies, will they bind? If there is no green antibodies, will they bind? The answer is absolutely not. They will not bind. That means no agglutination will occur. But if the antibodies are present and you add this anti-human globulin, which is the antibody against the antibody, they are going to agglutinate together, and this agglutination is basically a positive reaction. In the case of the indirect Combs test, normal RBCs are added to the patient serum. Okay, you add normal RBCs. Well, that's one step. What else? If the serum has an anti-RBCs surface IG, well, the RBCs will agglutinate when the Combs reagent is added, used for a pre-transfusion test. Let's try to understand what's up. You take from the patient his serum, not the RBCs. You bring the donor blood and you give the reagent. If the patient does have in his serum, he has the antibodies, agglutination will occur. If he does not have the antibodies, nothing will happen. Okay? So if he has the antibody, you will get yourself agglutination reaction. No antibodies in the serum, agglutination will occur. If you did not understand that, to make it simple for you, if the antibodies are stuck into the RBCs, we do a direct Combs test. If the antibodies are in the serum, we do the indirect Combs test. Indirect in the serum, direct on the RBCs. Whenever there is agglutination, it's a positive reaction. No agglutination, no reaction. We always need to use a reagent, which is an anti-human globulin. Okay, for the first test, which is the direct, it's going to be as follows. So again, the direct one help us to test for the antibodies stuck into the RBCs. Okay, so again, how do we do that? We add this reagent which is against the antibodies. Okay, we are checking directly against the antibody. So if this green antibody do exist, we will have agglutination. So they will just all of them clump to each other. But if the green antibody does not exist, no agglutination will occur. Everything will be okay. In the indirect Combs test, we are not checking for antibodies on the RBCs. We are checking for antibodies inside of the plasma. So I repeat, inside of the plasma, to check for them, you bring the RBCs and you bring yourself what? An anti-human globulin. The same thing. The function of anti-human globulin is to bind to the what? To bind to the antibodies. But think about it. If it will bind to it, what you will see? Literally nothing. So you must add one more thing. You add donor blood. So when you add donor blood, the donor blood will come here and it's going to bind to the pinkish antibodies in the serum of the patient. Now you give the anti-human globulin, which also will bind, and this will lead to a clumping reaction. When this happens, this is basically telling you that the patient serum does have an anti-donor RBCs antibodies. Okay, so let's speak about the platelet block formation. When we speak about the platelet block formation, it's a story. I just stabbed myself. What will happen? The first thing to occur is injury. So the endothelial damage, the moment you stab yourself, your endothelial cells will be like, shit, what should I do? What should I do? Your sympathetic nervous system will start a massive vasoconstriction in the area. So they write a transient vasoconstriction via neuronal stimulation reflux, and the endothelin, which is released from the damaged endothelial cells. Both of these are vasoconstrictor, which basically lead to contraction of the smooth muscle, decreasing the diameter of the vessels, which is a really good thing to decrease the blood loss. If you want to see it in real action, bring a patient with diabetes, just pinch prick his finger. At the first second, will the blood come out? The answer is no. But wait exactly 2 seconds and then just press on the finger a little bit. Will the blood come out? The answer is yes. The initial hit did not lead to release of the blood. Why? Because of the massive vasoconstriction that occurred because of the endothelium mediated vasoconstriction. Exposure. Okay, so let's speak about the story I always tell you, but now we'll speak about it a little bit deeper. So this is an endothelial cells inside of the vessels. Now we have an injury to it, just boom, it's destroyed. So what is going to be exposed? Subendothelial collagen. So the von Willebrand factor now is exposed to the collagen. So he's going to be bind to it. So von Willebrand factor. Now comes the question, where the hell did the von Willebrand factor come from? 2 locations. The first location is the Weibel-Baladi body. I like this guy. Yes. So Weibel-Baladi body, this is in the endothelial cells, and as someone said just right now, the platelets. And from the platelets, if you remember, von Willebrand factor, it has the letter F, so it must be from the alpha granules, right? Okay, so it comes from Weibel-Baladi body and from the alpha granules, that both of these are going to make the von Willebrand factor, which is going to bind into the subendothelial collagen. Okay, good. We have something. So how does this connection exactly occur? It occurs via something called the GB1B receptor site. Take a look here. So you can see the subendothelial collagen and you can see the endothelial cells. So this is the subendothelial collagen. It's binding the von Willebrand factor. For the sake of von Willebrand factor to bind to a platelet, it must utilize something called the GB1B. So the GB1B binds to the von Willebrand factor into a platelet. Okay, what else they write here? The next process is adhesion. Platelet bind von Willebrand factor via the GB1B receptor at the site of injury only. This is a specific reaction. It's really good because the aggregation and the thrombosis will be only at the site of injury. A platelet will undergo a conformational change in which they are going to release some substances. So the platelet are going to release an ADP and calcium. Does anybody remember these 2 particles, I mean ADP and calcium, are they secreted from the dense granules or the alpha granules? The dense one, absolutely. Remember the cache? Absolutely, the cache. So this is basically going to be the calcium and the ADPA and also the thromboxane A2. All of these are necessary for the coagulation cascade. The ADP will help the platelet to adhere to the endothelium. Let's take a look what is happening here. Well, yes, so the ADP will be secreted and it's going to auto-activate the platelet, okay? And also we can have a thromboxane A2 here, which also help in the aggregation process. Okay, so all of this stuff happening. Why it's important? Well, we just said ADP helps the platelet to adhere to the endothelium. We need to decrease the adherence. That's why we have medications such as clopidogrel, which prevents the auto-activation of the platelets for leading for the adherence. I mean, if I block this receptor, no adherence will occur for the platelets to the endothelium. Okay, so after this process occur, we will have the activation process in which the ADP, which is secreted by the platelet itself, is going to auto-activate the ADP receptor, okay? And that will induce something called the GB2B3A, which is expressed on the platelets. And that basically going to bind 2 platelets together. The binding of 2 platelets together, we call it aggregation. Aggregation, for the sake of it to happen, you need the GB2B3A, and for the sake of stimulation of this receptor to be expressed, you need an activation of the ADP receptor, as you can see. As you can see, the GB2B3A only is inserted and expressed only if you do what? If you do stimulate that receptor. Okay, good. So the fibrinogen is going to cross-link these two, and that can precipitate for the process of aggregation. Okay, we have our self-aggregation. So fibrinogen binds to the GB2B3A receptor and link the platelet. And now we have the following balance. We have a pro-aggregation factor and an anti-aggregation factor. A pro-aggregation factor include thromboxane A2, and you remember we can reduce this guy by using aspirin. Decreased blood flow also is a pro-aggregant. Why? Because the platelets are slowing down, so it's easier for them to clump. Also more platelet aggregation. Anti-aggregation factors include prostaglandins I and nitric oxide released by the endothelial cells. It leads to vasodilatation. Faster blood flow, all of these will decrease the aggregation. So there will be a temporary block which will stop the bleeding, but it can easily dislodge. You know, when you cut yourself, you will have this quick primary hemostasis in which just you have a minor wound that it will be blocked. But if you just try to like scratch it, it will just go off, right? That is what we have just made. This is a primary type of hemostasis. For the sake of making this basically block more stronger, we must go to the season 2, coagulation cascade in the secondary hemostasis. Okay, let's speak about the thrombogenesis again. It's what I just said, but in a different way. So you can see here the first step was the exposure, destruction of the endothelial cells, exposure of the subendothelial collagen, which bind to the GB1B with a von Willebrand factor. All of these are going to be bound into the platelets, which start to produce calcium and ADP. Calcium and ADP will help to, especially ADP, to activate the ADP receptor, which is going to lead to GB2B3A insertion into the platelet surface. And that, with the help of fibrinogen, is going to cross-link platelets, which lead to the process of aggregation, with the help of a pro-aggregant particles such as thromboxane A2 and fibrinogen. So they write here, formation of insoluble fibrin mesh. Aspirin irreversibly inhibit the cyclooxygenase. So it executes the cyclooxygenase, which is this guy. And that is going to inhibit the thromboxane A2 synthesis, which means less aggregation. Clopidogrel and all of the other grels, grel, and the ticlopidine, inhibit the ADP-induced expression of the GB2B3A by blocking the ADP receptor. And as you can see here, right? This drug is amazing for preventing restenting after insertion of a coronary artery stent. So we do use clopidogrel to prevent restenting after coronary artery stenting. Abiciximab and abitifabatide and tirofiban. Somebody told me these are the Fibians. Fibians because they have fib. Remember, the frog is a Fibian, okay? So somebody used to draw like a Fibian here, like a frog, and be like, these are the Fibians that are sitting on the GB2B3A. Okay, so they bind to it directly, inhibit it directly, preventing the cross-linking between that. So the next thing I'm going to speak about, the ristocetin test. The ristocetin is a test that we do to check the function of the von Willebrand factor if he is able to bind to the GB1B to the platelets. So you give ristocetin, and if ristocetin ristocetin test is failing, it's not happening. This will happen due to a dysfunction of the von Willebrand factor or the GB1B. Okay, so if either of these are dysfunctional, ristocetin test will fail to cause aggregation. Okay, so failure of aggregation with the ristocetin assay occurs in von Willebrand disease or something called Bernard-Soulier disease. So Bernard-Soulier disease, if you take a look here, you can see basically the von Willebrand disease, which is destruction of this guy. But if the GB1B is destroyed, Bernard-Soulier syndrome will occur. In this syndrome, you will have big suckers. What is big suckers? Big platelets, okay? So you will have a huge platelets that are known as big suckers, which is Bernard-Soulier disease. Okay, desmoglein promotes the release of von Willebrand factor and factor 8 from the endothelial cells. Guys, von Willebrand factor and factor 8 are dear friends. They are friends with forever. Whenever you have a release of one of them, the other will be released. Because basically they carry each other. Von Willebrand factors carries and protect factor 8. Okay? So if you take a look here, you can see von Willebrand factor together with factor 8 inside of the endothelial cells. Okay, nice. So this is it for now, at least. And you can see here the Fibians, the Fibitide and the Fibian, they are binding to this thing. We have a disease called the Glanzmann thrombocythemia, in which we will have a dysfunction of the GB2B3A, okay? Which is the exact thing as using ibiximab. So, but in case of Glanzmann's thrombocythemia, we will not have a big sucker, okay? We will not have big platelets. So the next thing we are going to speak about is the coagulation. Oh, I'm really sorry, guys. The time has finished. So, okay, guys, that is it for today. For tomorrow, we are going to continue. We finished it quite a lot. We finished 1, 2, 3, 4, 5, 6, 7, 8 pages today. That's good. Good. 8 pages per one day. It's amazing. 3, 4, 5, 6, 7, 8. Oh, yeah, 8 pages today. So that's it for today, and I will see you guys tomorrow at the exact same time. I will try to